Welcome to StudyNeuro. In this session, we'll be covering cranial nerves 11 and 12, the accessory and hypoglossal nerves, in our step-by-step bedside examination series. By the end of this lesson, you'll be able to identify the functions of cranial nerves 11 and 12, perform a focused bedside examination, and recognize key clinical signs of lower cranial nerve dysfunction. Cranial nerve 11 controls the sternocleidomastoid and trapezius muscles, making it essential for head rotation and shoulder elevation. Cranial nerve 12 controls tongue movement and plays a vital role in speech and swallowing. We'll also focus on how bedside assessment of these nerves helps localize brainstem pathology and detect lower cranial nerve lesions. Let's get started. When assessing the spinal accessory nerve, we focus on two key muscles, the trapezius and the sternocleidomastoid. These muscles control shoulder elevation and head rotation, which are critical for posture and coordinated movement. Begin by testing the trapezius. Ask the patient to shrug both shoulders against resistance and carefully observe for symmetry and strength. Next, assess the sternocleidomastoid by asking the patient to turn their head against your hand, feeling for equal power and smooth motion on both sides. Comparing right and left sides is essential to identify subtle asymmetry. In a normal examination, the patient demonstrates symmetric shoulder elevation and strong, even head rotation, with no evidence of muscle atrophy or weakness. Clinically, lesions of the accessory nerve are rarely isolated. They typically occur alongside broader brainstem or cervical cord pathology. When present, weakness may manifest as a shoulder droop, difficulty shrugging, or reduced ability to rotate the head. Evaluating CN XI in context with other neurological findings helps accurately localize lesions and guides further assessment. Now, let's focus on cranial nerve 12, the hypoglossal nerve. This nerve provides motor control to both the intrinsic and extrinsic muscles of the tongue, which is essential for speech, swallowing, and chewing. To examine the hypoglossal nerve, start by inspecting the tongue at rest, looking carefully for any wasting or fasciculations. Next, ask the patient to protrude their tongue and observe whether it remains midline or deviates to one side. You can also assess side-to-side movements and, if needed, apply gentle resistance to evaluate strength and symmetry. In a normal examination, the tongue protrudes in the midline, moves smoothly in all directions, shows no wasting or fasciculations, and has symmetric strength on both sides. Clinically, the pattern of deviation provides important localization clues. A lower motor neuron lesion causes the tongue to deviate toward the affected side, often accompanied by fasciculations and atrophy. In contrast, an upper motor neuron lesion may produce deviation away from the side of the lesion. Understanding these patterns is critical for assessing bulbar function and differentiating between upper and lower motor neuron pathology. That wraps up our review of cranial nerves 11 and 12. These nerves are key for moving your neck, controlling your shoulders, and coordinating tongue function for speech and swallowing. Careful bedside exams can give early clues to lower cranial nerve or brainstem problems, which is essential for accurate diagnosis and treatment. If you learned something new today, drop your takeaway in the comments, and make sure to like, share, and subscribe to StudyNeuro for more clinical neurology tips. Stay tuned for the next session, Neurosurgery Made Simple.